Hello, everyone. Welcome to this web lecture by Professor Giorgio Walter Canonica. He's a name that is so well known in the world, so it doesn't really require an introduction. But certainly, I would have the pleasure to introduce Professor Canonica. Professor Canonica has been a very close friend of APAAACI for several years, and he has been a regular speaker at all our conferences. Today, he will discuss his learning on COVID in Italy, but also specifically focusing on COVID-19, allergy and asthma, his experience and the global scenario. What are the facts and what are the unresolved scientific aspects? Professor Canonica heads as director of the Personalized Medicine, Asthma and Allergy Center of Milan's Humanitas University Hospital. He is also the past president of the World Allergy Organization. He's past president of the Italian Society of Allergy and Clinical Immunology. He's past president of Interasthma. He is also a council member of the Collegium International Allergicum. And he's been involved in so many guidelines and the leader of the SLIT guideline of WOW, which he initiated during his tenure as President WOW, which was actually a golden era of WOW. And most importantly, it's my pleasure to welcome Professor Canonica because he's been a friend and family to me for over 20 years. So, Professor Canonica, please.
Thank you very much, Professor Pawanko, for this very nice introduction. My task today is actually to talk about allergy and asthma during the pandemics. Of course, first of all, my disclosure of interest. Let me start first with the immune response and COVID. While we know that the virus is mainly infecting people through a couple of routes, through the conjunctiva and through the upper, through the mouth and the nose, and then is localizing mainly in the lungs. But to our task, what is quite important is to understand how important is ACE2 for our specific message and topic. You will know later why. ACE2 is the receptor for SARS-CoV-2 and is on pneumocytes. Now, the immune damage that is due to the COVID, to the SARS-CoV-2, well, is of course due to different steps with the antigen presentation and is involving both cellular immunity, innate and adaptive, and of course the humoral immunity. But what is the key point from an immunological viewpoint is this, is the cytokine storm with quite a few cytokines involved. And here you can have some possibility to block these storms, blocking IL-1 and IL-6. And these are the two options in terms of treatments that we already are using. Now, also the complement, as in our institution was demonstrated, can be involved in this. And as you can see here, actually, the complement system can play a very important role in this event. We very recently published with my two friends, Enrico Maggi and Lorenzo Moretta, what are the unanswered questions in terms of immune response. And we went through the different SARS-CoV in the past. The SARS-CoV, the MERS-CoV, and the SARS-CoV-2, just to evaluate what were the different responses, immune responses, actually both cellular and humoral, as far as coronavirus is concerned. And thinking about what is the impaired immunity or the immune evasion or the viral load, we got at the end what is through all these different mechanisms, we actually checked and we found out what is the very important difference. Now, asthma and COVID. Let me go to the topic that is nowadays the most important issue. Well, this title is a very provocative one. Does asthma make COVID-19 worse? I will demonstrate that this is not the case. How? Well, first of all, there is this paper showing that there is an interaction between type 2 and interferon and the interferon. So what does it mean? Well, look, here, I mean, there is a decrease in ACE2 or an increase when there are the interferons. And the interferons, of course, are part of the cytokine storm we were talking about before. But keep in mind that ACE2, I remind you once more, is the receptor for the coronavirus. And Jackson published something that is very, very interesting. Looking at the respiratory allergy and asthma and the expression of the receptor. Look, IL-13 is able to downregulate on nasal epithelium or bronchial epithelium in a statistical way the expression of ACE2, so the receptor of coronavirus. And once more, this is really an in vivo demonstration that whenever you challenge with a nasal challenge or bronchial allergen challenge, you are able to downregulate on epithelial cells the expression of ACE2. So let's say, in this sense, the allergic inflammation is decreasing the possibility to be infected by the allergic patients. Well, let's go to the clinic. And the clinic is that in China, this is the first report in China, with the calculation of the clinical features in 140 infected patients. Look, if you look at asthma and allergic rhinitis, for instance, there were no one. So let me introduce you to this paper that is currently submitted. And this is the evaluation we did in our Severe Asthma Network Italy, that is a registry about severe asthma. And we evaluate what's the impact of the SARS-CoV-2 in these patients. And first of all, let me show you that actually most of them are coming from the regions where the outbreaks was more impacting. And what are the data? Just 26 out of 1504 severe asthma patients, they have been infected. So this means 1.7% of the total, a very, very low number, and 34%, none of them, they experience a worsening of asthma in terms of clinical stuff. What is important that looking at the comorbidities that are nowadays very, very important in COVID patients, we found out that just the diabetes mellitus was the one showing a higher prevalence in our patients. And biologically thinking, what the treatment? In out of 21 out of 26 patients, they were on biological treatment, and the 71% of them, they were on anti-IL-5, whereas just 29% were on anti-IgE. There are some hypotheses about that. Nonetheless, what are the key points? First of all, patients with severe asthma, they are not at high risk of SARS-CoV-2 infection. There are potentially different reasons: the self-containment, of course, and an increased adherence to treatment. We'll see that. And a downregulation of the coronavirus receptors. And also, there are some data showing that inhaled corticosteroids, and namely cyclesonide, they can prevent or mitigate the development of the coronavirus infections. Higher incidence of diabetes and higher use of anti-IL-5 in our population, the ones that were infected. Allergic rhinitis, upper airway. First document published by ARIA and APAAACI. The message was very short and very, very important. The concept was go ahead with the treatment, go ahead with the treatment with intranasal corticosteroids. And what about asthma? Well, I can't start without mentioning what Gina proposed. And Gina proposed to go ahead with the treatment, namely with inhaled corticosteroid, to have an asthma action plan to be proposed to our patients, and to avoid, whenever possible, nebulizer. Why? Because of a potential risk of spreading the virus. This was published on March 30. Avoid the spirometry. Why? Because it might be a risk, again, to spread it. Follow the infection, of course, and look at, please, to the documents, and of course, the commitment to follow what are the local health advice or the local rules for each stakeholder, health professional, patients, healthcare system, and so. This was reported. Where are the link to get to the official document and recommendations? But I wish to share with you also what the NICE said a few days later on April 3. Why? Because first of all, there was the key message to minimize the face-to-face contact with the patient. So telephone, video consultation, and to cut the face-to-face appointment as much as possible, and to use all the alternative tools to be in contact with the patients. As far as the biological treatment, please go ahead with the treatment during the outbreaks, but whenever possible, as you can see in the last point, 3.3, monitoring biological treatment remotely is possible. But the last point is to promote self-administration and home care of the subsequent doses as far as biological treatment is concerned. So this is a very important message. This is the data I was just mentioning before. This is a quite, well, let's say, curious data, but it's quite important. Why? Because look, there was a clear improvement in adherence to treatment, which, as you know, is really a nightmare usually in as far as adherence to treatment in asthma and COPD is concerned. But probably, actually, the very important recommendations to go ahead to treat and to assume the treatment was very, very well accepted by the patients. And this is one of the results. Let me briefly also talk about allergen immunotherapy. The first paper came out from the American Academy and by a specific group that was reporting on allergen immunotherapy. And the general concern was to suspend in a reasonable way to suspend the subcutaneous immunotherapy, not the venom immunotherapy whenever possible, and to use other controller therapies during the temporary suspension of the allergen injections. What I wish to stress is, in this document, that is strongly discouraging the use of subcutaneous immunotherapy at home, there is no mention about sublingual immunotherapy. And another paper that was published 60 days later by Codispoti and co-workers, they were supporting the use of the telephone calls. They were of course, supporting the use of web-based tools for education. Again, the use of biologics, but as far as immunotherapy is concerned, they just reported the guidelines I mentioned before. No mention about sublingual immunotherapy was done. We published 7 days later in the Journal of Allergy and Clinical Immunology how an academic allergy unit during the pandemics should be, let's say, restyled. First of all, as our colleague on the other side of the ocean, of the Atlantic Ocean, well, we promoted the use of digital medicine. And as far as biologics is concerned, we supported the home delivery and we organized with our pharmacy an home delivery of the biologics. Whenever this was not possible, we referred to the closest center of our SANI networks. And we, for our teaching activity, we used an online platform. But we also stated that as far as sublingual immunotherapy, that is usually preferred in our clinical practice, and of course I'm talking about the airborne allergens. I mean, we didn't have the reason to suspend. Why? Because it is assumed at home, and we also organized, as for the biologics, with our pharmacy and home delivery of the sublingual immunotherapy. So, I mean, this was very, very important because we had no reason to discontinue the treatment, which was the case for subcutaneous immunotherapy, as I reported before. And let me tell you that this paper was very successful. Why? Because I posted on my LinkedIn profile, and in 2 weeks we got almost 9,000 visualizations. And this actually was one of the reasons why the European Academy of Allergy and Clinical Immunology and DARIA, we made a statement as far as allergen immunotherapy is concerned. And let me say, we are dividing the messages in infected and in non-infected patients. As far as non-infected patients, we suggest not to suspend allergen immunotherapy, and both subcutaneous and sublingual. I mean, of course, suggesting that sublingual immunotherapy can be taken at home. And so this is, able to avoid contacts with the potentially infected person. And then the reason is that we just be able to avoid the need to travel to an allergy clinic, to travel to a doctor's office, which is associated with the potential risk of getting infection. In a diagnosed case of COVID, we suggest to interrupt both subcutaneous and sublingual immunotherapy. This is a precaution, because we don't know yet how this can interact with the immune response during COVID. In the States, there was another very important issue: how to plan an allergy clinic. And this paper is evaluating allergic rhinitis, immunotherapy, and biologics, different diseases, and in 3 different parts. What are the shared decision making, the communication to patients, and the practice implications. To make a long story short, which is a very long one, no mention again about sublingual immunotherapy. Few words about biologics. Why? Because we have now this paper that is very recently published, and is a paper by the World Allergy Organization. What we need to know? First of all, 4 points. How safe are inhaled corticosteroids? Should biologics be used differently in the COVID era? What are the respiratory organization recommendations? Can we use biologics in patients with asthma under treatment for COVID-19? First, a few points. We reported all the official points of the companies related to mepolizumab, benralizumab, and dupilumab, and for this there were no data. There are some data about tomalizumab that are not strictly related to COVID, but there are some data about a reduction that the omalizumab is able to induce as far as rhinovirus is concerned, and also the reduction of lower respiratory tract infection and symptoms. What are the recommendations? Well, to make a long story short, I summarized. In the document is reported the GINA that I already mentioned, the American Academy one that is suggesting to use the medication because we don't have yet any data in clinical practice. The American College supporting the use of the treatment, and also the European Respiratory Society. But also national societies were mentioned in the document. Why? Because, for instance, the British Thoracic Society or the Italian Society, we did actually a document, and we released this document and for all the patients and the centers, just to address how to deal with these pandemics. Can we use the biologics in patients with, there are no theoretical interference, so we'll go ahead with the treatment that should not be discontinued. Biologicals, is not recommended to be suspended, and we mention once more that comorbidities such as obesity, cardiovascular diseases, metabolic disease can be of some impact in as far as mortality is concerned. But one more reason to maintain the control of the treatment, as mentioned in all the previous documents. And the aim is to get a registry of COVID-infected people in severe asthma. So how to deal nowadays with an asthma and allergy clinic? Well, I mentioned again the Codispoti paper that I mentioned before, and the special article of Shaker. Why? Because all of them, as the one that we described that we have currently submitted, are talking about how to have an innovate and integrate model for the new precision and digital medicine. First of all, sorry, what is the differentiation between the symptoms? Clinically speaking, what allergen are able to induce in the upper airway and what SARS-CoV-2 is able to induce, and the differences are quite clear from a clinical viewpoint. Think about fever, think about shortness of breath, and whereas we don't have in our upper airways allergic patients. But in addition, I wish to stress the point that how the allergy clinic should be reorganized. And if you look at here, telemedicine is becoming more and more important in all the diseases that we are treating. And accordingly to this view, once more, the European Academy and ARIA, they propose a position paper how to organize an allergy clinic due to the pandemics or during the pandemics. And let me say, first of all, as I mentioned before, we made a recommendation, but also recommendation how to organize the best management of the clinic during the pandemic. Of course, protective measures, to know a lot about the viral infection, as I mentioned in the previous part, how to deal about the triage or the assessment, the pre-assessment of our patients, depending of course, the different disease, and as much as possible to have tools for remote controls of our patients. And technology is a key word. Nowadays is really a key word in this new scenario. And the digital health solution are what we do need today. So let me spend a few words about the digital medicine in this context. Quite recently, Jay Portnoy and colleagues, they were talking about the good, the bad, and the unknown about telemedicine in asthma and allergy. This was before the outbreaks. And whereas we are already talking about the tomorrow in this paper, this is the implication of telehealth in a post-pandemic. And once more, Jay Portnoy said, well, telemedicine in the era of COVID-19, this was published in May 2020 in the Journal of Allergy and Clinical Immunology, and talking about telemedicine video visit. And let me go back to the papers we published, and digital medicine is becoming very, very important in each moment of the current organization of the allergy clinic. Why? Because we can keep a relationship, even more than before, between physician and patients. We can interact with our colleagues, and you know that nowadays the multidisciplinary approach is absolutely important. And then we can collect data in the electronic health records. And you know that nowadays the big data are so important to get new informations. And that's the reason why I wish to touch base on this very interesting and triggering paper. Why? Because the lady who published it is a primary care physician in Scotland, but I was attracted by the title, that is The Art of Medicine Before and After COVID. And she was publishing quite a lot of books on evidence-based medicine too, but I mean, she was focusing on one point. Well, actually, the changes in the national healthcare system usually happen so slowly, I must say, not just in Scotland. And also, we were said about telemedicine for a lot of time. But then suddenly, the technicians were working around the clock. And in a week, we were able to use these tools. I must say, finally. So telemedicine and telehealth are nowadays part of our job and part of how we can deal better with our patients. So let me go to the conclusions. There is, as far as asthma is concerned, there is low incidence of CO2 infections. Immunological mechanisms possibly can explain why this. Asthma control and adherence to treatment is mandatory. And I wish to underline once more how this was effective in improving adherence. As far as severe asthma, the diabetes is a risk, and the biologics treatment should go on in terms of safety. Allergen immunotherapy, both SCIT and SLIT, should be continued in non-infected patients. Of course, I wish to underline once more how SLIT is preferable due to its flexibility for the home administration, and SCIT and SLIT should be suspended in infected patients because we do not know yet what the impact could be, although I'm quite positive about that. And as far as allergy clinic, well, we should really adopt a different approach. And of course, following what are the local and national regulation to protect all the patients and nurses and doctors. The scientific societies, they should have a role releasing statements how to manage in the regions, in the countries, these new realities, and we should become aware of the importance of digital medicine, because let's say that it become necessary and unreplaceable in several realities, and we realized that this should be the case even independently of the pandemics. And this is also teaching us how can we better interact with the patients. And so the more we can be trained, and the more we could use new technologies, this will empower our professionality as a doctor and our partnership with our patients. Let me conclude thanking, of course, all my group in Humanitas, and I'm available. If the case, you can contact me on this mail address. Thank you very much for your attention.
So Walter, thank you very much for this excellent talk. It was so informative as usual, and we deeply appreciate the extent of coverage that you have done on this very important topic of COVID-19 in relation to allergy and asthma. Can you please tell us about which cytokine is more important? Would it be IL-1 or IL-6? And what do you have any idea about IL-25?
No idea about IL-25, whereas we have some trials ongoing with anti-IL-1 and anti-IL-6. Possibly anti-IL-1 is being higher in the cascade, might be probably more impacting, but we do need actually to have the data of the trials.
Okay. Thank you. About IL-13, you mentioned about IL-13 downregulating ACE2 receptor, which is the SARS-CoV-2 receptor. And we know that allergic inflammation reduces it, but in well-controlled cases, the levels of IL-13 may be low and the interferon gamma levels may be high. So do you have any comments on that?
Well, the comment is that as far as IL-13 is concerned, there are also some publications showing that dupilumab was used during COVID, and the results were, I mean, not interfering with the COVID. So there is no concern about it. As far as I mean, the other option, as far as interferon, there are no data yet, although I'm aware that there are some application of some interferons by inhalation, and there are ongoing trial. So I think that at the end of the story, we will have a lot of new data to think about, and how to interact, and the interaction between the different immune response will probably more clear.
Thank you, Walter. We advise our patients with asthma and allergic rhinitis to continue their inhaled and intranasal steroids. And as you showed in the guidelines also, it's the same recommendations. So do you think that that can actually prevent the development of COVID in asthmatics? Is that why we see less comorbidity with of asthma in COVID patients?
Well, in any case, the patients should have the best control is possible. Why? Because if they have an asthma attack, they have to go to the emergency department, risking infection. So this is, of course, one of the reasons. On the other side, there are some data are still sparse data concerning the effect of some inhaled corticosteroids, namely cyclizonide. But nowadays there are trials approved about the use of cyclizonide in asthma patients during COVID, and so we'll see what the data are.
Yes, I mean, some of the postulations is that cyclizonide actually is effective in reaching the small airways and may have some role in reducing the viral replication. But yes, as you said, we need to wait for more data. Do you have, among the different biologics, would you have any idea of how these biologics would interact with any of the antivirals like remdesivir?
There are no data yet.
Okay.
I have no data.
Okay. And what is your comment on the role of potential vaccines in COVID, and how do you see the progress for the development of vaccine?
Yes, this is the answer. And I hope our colleagues involved in this will be very, very successful and as soon as possible. This is the way to control.
Okay. And finally, I'd like to ask you about this very important aspect that has come out of this COVID is telemedicine, or what you have referred to as digital medicine. And looking at what we are facing today in managing patients in this COVID situation, we're looking at what happens post-COVID. Will this change the way we practice medicine? Will digital medicine become the new form of how we practice medicine?
Definitely. And let me say that nowadays we already have really an implementation of a remote control of the patients. And I think that this is one of the worries was, I mean, how to build this kind of interaction or this kind of remote visit. But as far as I know, both in the States and in Europe, this is solved. But let me also say that this is possibly a way to interact more and more with the patient, because I mean the time consuming for both the patient and the doctor is much less. So you can have more often the possibility to follow the patient, and of course this will help us. And when I'm saying us, I'm saying patient and doctor to have a better outcome.
Thank you very much, Walter. Deeply appreciate your time and your excellent talk. And I'm sure all our APAAACI members and all the people who will be actually watching you on our website and through our news and notes would be extremely happy to hear you. And we'll be back with you on other topics of interest. Thank you very much, Walter.
Thank you very much. Bye-bye.
Bye-bye.